Hey everybody, on behalf of the Division of General Internal Medicine, I'm pleased to introduce today's Grand Round speaker, Dr. Joshua Sparks, an associate professor in the Department of Pediatrics. Dr. Sparks is a Kentucky native and completed medical school, internship, and residency here at University of Louisville. He then pursued two subspecialty fellowships in pediatric cardiology and pediatric heart failure and transplantation at Washington University in St. Louis. He returned to UofL in 2012, at which time he started the Pediatric Advanced Heart Failure and Transplant Program at Norton Children's Hospital. A health challenge he plans to tell you about today forced him to leave clinical medicine in 2020, but he was able to return to the bedside in 2023, fortunately. Dr. Sparks is currently the director for the Pediatric Cardiovascular Research Fellowship, or Research Development for Norton Children's Hospital Heart Institute, and he serves on local, national, and international working groups and committees on heart failure, ventricular assist devices, and transplant in children. Please join me in extending a warm welcome to Dr. Joshua Sparks.
Thank you so much. Hello, good morning, everybody. Sure. Oh, we pause that, right? Yeah. Resume there, I think. Resume.
Oh, right
here.
Oh, yeah, that would help.
Yeah.
There we go.
Okay, I hope people who are on Zoom can see my screen here. Does that work? All right. I appreciate the invitation to give you a talk today. I gave this a somewhat similar presentation to my department, and they felt that it would be beneficial to adult physicians taking care of adults. And so we'll get started here. Does it not working? Let's see. There we go. So thanks for the opportunity. So what this is really probably a little bit more informal than you may typically see. It's a heart-to-heart about what my experience and knowledge that I've gleaned from being diagnosed with a rare disease and a chronic medical condition. And I'm hope to, through my experience, help you sort of think about your patients a little differently, particularly ones who have unusual or rare diseases or challenging diseases. What this is not is a rigorous scientific review of my diagnosis. It is not a lecture about the healthcare system, and hopefully but still I hope you can apply this to your patients. I have really no disclosures, except I don't really use things off label, but there's really no on label medications for my disease. So anything I might say would be off label. And some of the ways I use some of my devices in my life are sort of an atypical way to use them, but it's how I get along. And then my second apology is for my voice. This is sort of part of the disease, and I'm sort of in the middle of a little flare at the moment, so I don't have much of a voice. I'll be sort of sipping through the talk. So just a little bit of pediatric heart failure transplant cardiology, and I was diagnosed with a rare disease called relapsing polychondritis. If anybody in the room has ever heard of this condition before, and we'll talk a little bit about that, and it required an extended medical leave. Relapsing diseases. What is it? Is it an inflammatory disease of, we don't really know. We think is related to cartilage, although the phenotypes are so different, it's really hard to say. We do know it has something to do with an antigen in some one types of the proteoglycan classification. It's a clinical diagnosis, but that's imperfect. The 5-year survival depends on which organ systems you have that are involved. It can be as low as 70% to as high as 90%, and there's actually some that I would give higher than that. There's no FDA-approved medications, but you have a significant amount of autoimmune overlap with Sicca syndrome, rheumatoid arthritis, autoimmune thyroid disease, and such. But these are the criteria. I won't go over that study, but you can tell that there are different types of cartilaginous structures within the body that become inflamed and ultimately damaged. One of my physician that I worked with, Dr. Marcy Ferrata, classified them in 3 basic subgroups. You can involve the ear, nose, the lower respiratory tract, and or a hematological tract, which has really been reclassified into a syndrome called VEXAS. So it can involve the vocal cords and the upper airway, the trachea. It can involve, which we'll see, which is my problem, or the ear. This is my ear. Intermittently, it will become red and inflamed and painful. Ultimately, you can have damage to the cartilage if it's not treated and can develop what they really say cauliflower ear, which I think is horrible, but that's what we call it. It can affect the eyes with scleritis, episcleritis. Sicca syndrome can lead to sort of dry eye, dry mouth, with broken teeth and all of the sort of sequelae from that. Involves your wrists. My problem is my wrists and my ankles and my toes are particularly painful, and then my thumbs and my PIPs. This is one of my CT scans that in part of my journey where the airway is narrowed. You can see down to the carina and the mid-trachea, and then which leads ultimately to air trapping and significant areas of ground glass inflammation. And so, what's the treatment? We really don't know. There's not enough patients to really do treatment studies. It's a likely combination of T and B cell inflammation, and any immunotherapy you can think of has been tried. But damage is generally irreversible because we cannot regrow cartilage in our bodies. But it's really about the journey, not so much the diagnosis. It's how do we get to the diagnosis, and then taking the diagnosis and moving forward with it is really what I want to talk about. So sometimes my life looks like this, a few bumps in the road, sort of some potholes. Sometimes it looks like this, a total dumpster fire, where things are just falling apart. And you never really know what the day is going to be. It's like this morning, I had no idea how I was going to sound or feel. Sometimes I can't walk, sometimes I can't breathe, sometimes I can't talk. It just varies. But ultimately, the goals for today are to understand a diagnostic odyssey. And I don't know if you've heard that term. If you haven't, I hope you will leave understanding that and to understand some specific things to be aware of as a physician of a patient with a possible rare disease or ultimately with a rare disease, to hear through my experience as a doctor some of the challenges of having a rare disease and actually understanding how the role of palliative care can improve outcomes for patients with challenging diseases. And so, what is a rare disease? NORD defines it as a disease occurring in less than 200,000 Americans. There's been over 6,800 rare diseases currently, but roughly 1 out of 10 Americans, believe it or not, has been diagnosed with a rare disease, which is 30 million patients. So actually having a rare disease isn't that rare, but each individual disease is rare. And it's an expensive problem. Almost $1 trillion was spent on 15 million patients with 370 diseases in 2019. And we only have treatment for 5% of them and pretty much all labels. It says most, but pretty much all, other than some of these new genetic genetic therapies are on label. They present unique logistical problems for patients, the challenges of the diagnosis. The challenges extend beyond the physical, so it's incredibly emotionally challenging. Economically, since everything's off label, insurance can be a challenge, and sometimes you have to pay out of pocket for devices and for medications you need. And socially, looking at me, if I don't say anything, you wouldn't know that I was sick. You would earlier, but not now. For clinicians, there's a total lack of knowledge of these diseases. You wouldn't be expected to know every single rare disease when it represents less than 0.01% of the patients you see. And there's lots of overlapping symptoms, as you'll learn I was diagnosed with asthma, and it was because I had a cough and I had a wheeze and I was short of breath. And so, and there's a total lack of guidelines on what to do. And then research is its own actually worse problem now, but trying to find research funding for a rare disease that affects very few patients that would be incredibly expensive to study because it's poorly powered, because there's not enough patients. So you would need an extended, prolonged period of study, which would be really impractical for most people to use. For you guys, it's a little bit challenging because the patients have to become the experts often. And rare diseases exude no loneliness. The whole idea is a rare disease puts you kind of by yourself. And these diseases are not alike. And you hear, I don't know, or I don't know what to do, or I don't know what's best for you on the repeat for every doctor. Now, all your patients aren't going to be as fortunate as I was, who was able to join the NIH team and write the most recent clinical best practice on your disease. So, but that was sort of because I was a physician, and but it helped me get to know my disease. Now, I don't know how good that was for me personally. Professionally, it was a great thing. But personally, it gave me too much knowledge about my disease in some ways and created a lot of anxiety. And there's no natural history to really understand and predict your outcome. And it's really exhausting. So I've used this phrase already, the diagnostic odyssey. This diagram was put together by EuroDis, which is the European Organization of Rare Diseases. And it's something you probably wouldn't be surprising. It's just putting it in a diagram makes it a little bit of a different, it gives you a visual. So patients ultimately have symptoms and they go through the diagnostic process and they get given a diagnosis, which isn't the right diagnosis. And then you do it again, and then you do it again. And then eventually, this probably has multiple repeats, but you eventually, often it's genetics, right? When you get to the geneticist or genetic counselor, that you ultimately get the diagnosis, which can lead to the actual diagnostic treatment. I'm not going to go through the whole thing, but mine, I started with asthma as a child, and that really led to a lot of problems in getting to the real diagnosis because I probably really did have asthma as a child. But this led to, about 10 years ago now, 11, 12, my first year of fellowship, I was admitted to the hospital with severe shortness of breath and cough. Now, this cough wasn't a, that was not my cough. My cough was these extended periods of just recurrent where I couldn't even catch a breath to the point my lactate was 6 when I got to the emergency room. And I had a CT scan, I had no PE, but I was biased because the people who brought me in said he has asthma. So the first thing that you would think of was he has asthma and everything fit in. And I don't judge these people like of everything that would make sense, right? You don't start with, these rare, unusual things. But and these were my PFTs when they came in. So I think they're reasonable to think I had airway obstruction and steroids made it better. So why not, right? Um, However, it was incredibly refractory. So I saw one of the leading asthma specialists at Washington University, right? That's where I was at. There were all the geniuses there. Took me back to the basics, did a methacholine challenge with a PC20 of 2, did all this provocative testing, and ultimately still had severe persistent asthma. But of note, I did have 50% tracheobronchomalacia at the time. But we ultimately was on 2 inhaled steroids, LAMA, Xolair, Theophylline, EpiPen, steroid, and then we could not taper the steroids. I was on steroids for up to 6 months, and was every time we would reduce it, it would come back. And I had 3 TCU level admissions. Fortunately, no intubations. Readmitted. So this is sort of how things work. Ultimately, had my CT scan done more locally, and this is my sad face. This is sort of at the area right above the carina. You can see sort of flattened out and curved. And this is in a held expiratory state. So during airflow, it's probably near completely collapsed. So ultimately, everybody kind of got nervous. I've been bronched and had all the workup, and we still an assessment. You have this sort of 7 years of this disease, all of these medications. You have, then I was on chest physiotherapy, hypertonic saline, intermittent daytime BiPAP, N-acetylcysteine, which is a horrible thing to breathe if you haven't breathed it. And then all of these findings, and I was still left with the diagnosis of asthma. Everywhere I went, asthma, Cleveland Clinic, asthma, everywhere, asthma, everything. And all I got was from my friends and relatives is I'm worried about you. And I didn't know what else to do. And I swore I was taking all of my medicines. I was a really good patient. But I began questioning my own sanity at this point. I would spend hours just staring at my CT scan in lack of belief of what was going on with me. And which led to this feeling, incredibly isolated. And then things progressed, as we know, and it eventually hit a tipping point with fever and cough, shortness of breath, and everything was out of options. I was admitted to the hospital and started doing my own Google searching about what in the world could be going on with me. And finally found this editorial, which really goes to the benefit of editorials sometimes, because this is Marcy Ferrata. She is a physician, and our symptoms nearly overlapped. And she made recommendations to my team, got pulse steroids of 4 grams of solumedrol, but I could breathe for the first time in almost a decade. And it was an incredible feeling. I had no cough for 24 hours. And it was an amazing feeling, which you can see like by my smile in my hospital bed. Now, unfortunately, all this happened during COVID, so it took me forever to get to the NIH. And this was the testing they did. It was pretty elaborate and exhaustive. My only findings were type 2 collagen, which used to be thought of as a diagnostic test for relapsing polychondritis. But if there's any rheumatologists out there, and can be non-specific findings. But they did review my CT scan and felt that there was areas of chondritis on my imaging read by the experts, and therefore it established the diagnosis. And this is my team with Marcy and Wendy and myself. And you can see already what the steroids had done to me over that short period of time. So this is the completion of my diagnostic odyssey of over 10 years. I'm finally getting to my diagnosis. So, in reflection, what are things that you can do, and what should you be aware of? Well, first off, are biases that I think that we learn about, but we don't often think about. I'm not going to go through every one of these, don't panic. But there are a number of them, and these aren't even a complete list of all the potential biases that we could have in dealing with a patient. Ones that I think were important for rare diseases, and for me in particular, were anchoring, lock on my first symptoms, and then confirmation bias. You find things that support it, well, then that's supposed to be what it is. Diagnostic momentum. Well, everything was pointing to asthma, so everything just sort of continues on. Premature closure is one that happens to all of us, right? We all get this. Oh, well, you get signed out a patient, and that's what the diagnosis is, and you forget to sort of think broader about the patient. And then triage queuing and early diagnosis really drives everything, and you don't broaden your differential diagnosis. Other patients deal with bandwagon effect, multiple alternative diagnoses, and then search satisficing. I always can't say it, but when you find something that seems to fit, I almost was my own victim of that. I found something, and that must be it, right? Because it all lines up. And then when you work really hard to find the diagnosis, it's really hard to get away from it sometimes. And frankly, the most the challenging one with the rare diseases we're all taught in medical school, right? Something that this guy said, Theodore Woodward, when you hear hoofbeats, think horses, not zebras, right? Well, zebras do exist. And I think that you have to kind of think about patients and that aren't fitting the picture. And so what I tell my trainees frequently is, with diagnoses, you have to pick it and stick it. You have to at least make a diagnosis and treat it. But remember, your first diagnosis is often presumptive. It almost always is. Very few patients meet everything by the book, got the diagnosis, it's done. And so follow-up is really the key. If a patient's not fitting the diagnosis, then you need to stop, go back, and then reassess what you're doing. You may have to start from the beginning, but that's the right thing to do for the patient. And then also be thoughtful about your possible biases. And what else can you do? You can ask yourself, is my patient stuck in an odyssey? How do you do that? You go back through the chart. And I empathize particularly with adult physicians and the amount of patients you have to see and the amount of paperwork that you have to do, and the insurance companies. It's probably multitudes worse than what we deal with in pediatrics, I would suspect. Not an adult physician, but I would bet. Especially you have to deal with Medicare. But but I think taking the time at some point, or distributing that to somebody else, but go back through the past 5 years if your patient's recurring and your patients are saying what you're doing is not working. Schedule, sorry to say, longer visits. Having somebody go through your schedule and find the time for at least the 1 or 2 patients out of your week that really need that time. It is incredibly frustrating as the physician to do that. I know from experience, and when you have the review of systems, that's positive, right? That's sort of what it is. Everything is positive. And these patients are frustrated and they're scared and they're anxious and they want you to fix them. And when you say, I don't know, they get frustrated, but it's what they need. And sometimes you're the only person who can give them the empathy that they need. And the other thing I would tell you, what I learned is, don't minimize the strain. Just because you haven't seen it, it doesn't make sense. It sounds silly. It may be incredibly the biggest problem for the patient. Why do I have a person with a head of fire? Well, when I was on 80 milligrams of prednisone twice a day, I had what we think now was probably some sort of repetitive catechol surge. And my face would turn bright red, and it was incredibly painful, and it felt like my face was melting off. And so I would call, and what do you say to your doctor? Well, my face is burning. Well, okay, that doesn't sound very intense, But if everything going on in my life, I couldn't breathe, that was what was really driving me crazy. And we eventually, when somebody listened to me, we went through some things, tried clonidine, eventually propranolol. I went through this for 3 weeks. We took one dose of propranolol. It was gone in 20 minutes after 2 weeks of literally, you have to see me in a fan, but then in a chair with a fan, all these fans blowing, my wife putting cold. It was incredibly, but how do you describe that to somebody? Right. And so it just, I think when things don't make sense, just make sure that you're getting all the information of what's the worst thing that's bothering you right now. I think that's the most important question sometimes. And I hate to sound preachy. I really do. I know we've all been there. And so this may not apply to any of you. But if you can pick up one of these things that you aren't doing, I think can ultimately help you be a better doctor. And some diseases are invisible, like I said earlier. I feel this on the daily. You can only see on the invisible that I feel all the time. It would be helpful to kind of understand me better. And then the other thing for you guys, I have a multitude of subspecialists, but without my primary care doctor, it doesn't work. You guys, as internal medicine doctors, I don't know how many of you guys are the outpatient in primary care doc or the hospitalists. I know it's all different now, but these outpatient primary care docs are critical to success for patients like me, as I call them the linchpin. And being able to provide education about my disease, but also listen to me and hear information about my disease and learn with me so that we can go through it together and that I'm not alone. And take the time to call the specialist directly. You don't have to do it every single day, but I don't know how many times that I went in and not to my primary care, but some former primary care doctors. They, read the notes. Well, that's great, but with rare diseases like this, you really need to talk to the specialist and get understanding about what's going on with the disease. And obviously, help in coordination. Sometimes it's a mess, and it's way more challenging than I ever thought on the patient side of things. And then, so going back to the diagnostic, understanding the diagnostic odyssey is one thing, but experiencing it is a totally different thing. And so we all know the stages of grief. Well, you go through the diagnosis, you get your stages of grief. We all know that and understand that. But denial is a very real thing. But denial with this wasn't, I don't call it denial because I didn't think I wasn't sick. I didn't think that that wasn't the problem. I was totally committed to the asthma diagnosis. But this was me going to work. I would take now I'm not advocating doing this to yourself, but I would go to work and taking my treatments. And then I would round on the patients, and then I would go to my office and sit on my BiPAP for 2 or 3 hours while I did my notes. And it sounds crazy afterwards, right? I didn't think I was nuts during the time, but I was literally doing this on every day when I was on service, doing clinics. It was a lot. And eventually this happened all the time. And so I would follow this pattern. But, was this really denial? I don't think so. I don't know what to call it. I created this phrase, this symptom coercion, sort of trying to coerce your symptoms that you've been given, or that coerce your symptoms that you have into the diagnosis that you've been given, which is what I was trying to do. I'm not trying to minimize asthma. Asthma is an incredibly dangerous diagnosis. Patients clearly die from asthma. But in my mind, I just had asthma. I just had to figure it out. I had to take my medicines, and I knew the natural history of asthma. I knew what I needed to look out for. So I was trying to take this square peg and put it in a round hole. And it just wasn't working. And so this is what my life was like. And then when you have in the Odyssey, you're getting these recurrent misdiagnoses or the same diagnosis over and over again from different symptoms, you're experiencing those stages of grief repeatedly, right? When you get a diagnosis and then you come back to it and then it doesn't work and you get another diagnosis. Remember, these patients are going home and thinking about this and going through these stages every day, and it's exhausting and confusing. And you start to lose trust in the doctors and importantly yourself. I can't say enough about how much these patients who are in these situations are questioning their own sanity in their mind. That am I making this up? Is there something I'm doing? I had oxygen levels of 85, and I would wonder if somehow I was doing that to myself. Like, I don't know how else to describe in craziness, but that's really where me as a physician, was. And we as doctors are set up for this, right? And if you, I don't know if anybody read the Handbook of Physician Health. I can't say that I've read the whole thing, but they talk about how our perfectionism and responsibility, sense of responsibility, and our self-doubt and need for control. And particularly, I had guilt altruism where I needed to be there for my patients at my own health expense. And so we do this and we ignore our own health. And so physicians like you guys are incredibly set up to do what I did, which we'd all say was kind of crazy, right? And just a tad nuts, and a little dangerous for myself, right? So then once you finally get to the real diagnosis, you think that there's relief, right? Well, that relief lasts about 10 seconds because then, oh my God, I have a rare disease that nobody knows what to do about, that has a natural history that who knows. And I don't know how long I'm going to live. And these symptoms of asthma that I thought we were going to be able to find an ultimate treatment plan for is totally tossed out the window. And I felt like that. I didn't feel relieved. I felt terrified. I felt like somebody just dropped the piano on me. And so then the cure was this. I mean, these are my pills, these are my shots. And and so you get remission, right? I'm in there getting my maintenance. I ultimately am on tocilizumab, prednisone, methotrexate, hydrochloroquine after multiple medications that we're trying to work through, which then in and of itself was unpleasant. I had a horrible reaction to TNF alpha blockers, and MMF is really not a pleasant drug to be on from a GI perspective. And steroids, well, you'll see what happens when you take steroids here in just a minute. Ultimately, I became handicapped. And so this was me before my sickness. And then steroids, immune suppression. We also found a small micropituitary adenoma that was active. And so we had panhypopituitarism. And I went from that to this. And this is from a Zoom call that I had, that I just happened to look at myself and could not believe that that was me. And so I snapped a picture just in case I ever forgot how sick I was and wanted to kind of go back to the stuff I was doing. I wanted to try to protect myself. But despite having remission, my inflammation was remitted, right? But the cartilage damage was done. And I personally think that when the inflammation from the airway was gone, the rigidity that was there was less, is my own personal sort of thinking through it. And I think that my air hunger got worse because the inflammation that was helping to stent the airway open was now gone. And so now, without the edema, et cetera, I think there was worsening of the airway collapse. But nobody in their right mind would go into a patient who has relapsing polychondritis' airway. It's incredibly dangerous because you can get a significant flare in a short amount of time, which can lead to a complete airway obstruction. And that could be bad. But for a minute to talk about air hunger, I don't know if anybody in this room has experienced air hunger before. It's not dyspnea. It's not shortness of breath. It's a unique sensation. I personally think my air hunger isn't just my obstruction. It's also all of my obstruction is in my carina, which is where it's all innervated. And that sort of sensation of either intra-airway high CO2 or whatever the physiology is, it's incredibly powerful. And it feels like you are underwater and you're going to the surface and you got that burning. I got to catch my breath. You get panicked, if you go down too deep, but I'm breathing and I'm trying to catch that. And you're so hyperinflated and so air trapped. There's no amount of inspiration that you can find that fix that. And it's incredible. Whoa, where did that go? That should not be it. Oh, yeah, I guess it is. And so along with the curative therapy, I needed palliative therapy. I needed somebody to help me with my symptoms because the inflammation was under control, right? I didn't need any more tocilizumab, definitely didn't need more steroids. I was debilitated. I could not walk. I was in a wheelchair. I couldn't take my dog on a walk without feeling incredibly anxious and panicked. And so I needed palliative care because this is what air hunger does to your brain. You fear, the anxiety, the emotional memory of what might happen. I might started being fearful of what might cause air hunger, right? And so how did I manage? It was incredibly challenging to work. And it's not something that you guys necessarily have the tool set to manage that. It can bypass, what the internal medicine doctor might feel comfortable with. And so let's say thinking about palliative care. This is sort of an old model, the top model, where you sort of do all the life extending, prolonging curative treatment, and then you call palliative care and then you call hospice and the patient expires. I still think some people have this in their mindset, but this should be outdated by now. And if you look at more recent a diagram, to have a better one in a moment, but you at least start the idea of palliative care at the same time of curative care. And what I've learned, and this was before I got sick as a transplant cardiologist, these children who are dying, and you transplant them, they're still palliated, right? It's a palliative treatment, transplant is. And so I consulted palliative care on every patient that had heart failure because heart failure is essentially a terminal diagnosis. You can extend it, you can prolong it, you can transplant it, but it's still a terminal diagnosis. And we do palliative care all the time, Tylenol, ibuprofen, right? There's things that we do to help patients, Phenergan or Zofran. Those are all palliative medications to help the patient feel better. It doesn't cure them. It doesn't make their disease go away. And so I think starting to think about what supportive care, palliative care, and what is curative care, and separating those out and thinking about that for patients, and creating a model that's more like this, where palliative care starts the very, very beginning and grows as the disease progresses. And so, at some point along this way, you're going to say, well, this palliative needs have exceeded what I can do. And then you call a palliative care team to help. And I think thinking about it that way will help you kind of know when to call palliative care and how to utilize them better. How much palliative care am I doing versus curative care for the patient? And I think it's critically important to have that in your mind because it's how to improve the patient's quality of life. And nothing is more expensive than a missed opportunity. So these were a couple of studies. See, I'm using science in this. I promise. There's a little bit of some science here, but looking at people in the population in the United States. This is from as recent as 2020. Only a third, less than a third, even know what palliative care is. And almost half of them who knew what it was thought it caused death. They believed that treatment had to stop, that it was equal to hospice, that it's giving up. Only 13% really didn't have a misconception. That's 13 of 30%, right? So very few people really understood really what palliative care is. And then if you take a look at you guys, there's some survey studies out there that have looked at physicians and it's really kind of confusing data. This was the best that I could find that I thought had a good take-home message that people wanted to provide early palliative care, but there were barriers. And I think these are the things that it said that were the barriers for primary and palliative care to work together. Is there sort of delineation of roles and shared care with needs-dependent referral, adequate resources to support the primary palliative care. But I think it's important to still, one of the problems is addressing the misconceptions of what palliative care really is and what role that they can play. And from my own experience with my own former primary care doctor, because of my experience as a transplant cardiologist, sorry, the voice is going, but these were the responses. Oh, let me call you later. Then she thought I was suicidal because she thought I was just ready to call hospice and give it up. Let's just go home. Then she was like, I'm concerned. You're not really sick enough. I don't quite understand what you're saying. She was totally clueless as to what. So fortunately, you don't have to have a referral for palliative care. And I talked to Dustin Dillon and got a referral for myself, which was the best thing that I did for myself. So what is palliative care? If you look at the WHO definition, you don't have to read all the words. You can see these important things. It affirms life, relief of symptoms, offers a support systems to live as actively as possible, enhances quality of life, and positively influences the course of illness. And it should be used early in the course of illness. And so there really isn't very little that talks about it's time to die, right? That's not really what palliative care is for. So what it was my experience with palliative care was, well, we had established goals. Okay, this disease wasn't going anywhere. I had to figure out what I wanted, and for me, surprise, surprise, my number one was to go back to work. Right? I'd been on sick leave and I was miserable. I'm sure you guys could all relate. If you had to go home and not be a doctor for 6 months, it would drive you crazy, right? And I spent 12 years of my life after school, medical school training to do what I did. And that was my baby. It was my program. I was gone. And it was incredibly painful for me. I ranked it above free from air hunger. Okay. And these were ranked. And I wanted to be able to walk. Those were my first three goals. And I love this t-shirt. So I just put it on there. And so the palliative care plan, though, was a little bit different. They said you need to stop working. And Bethany, my palliative care physician, said, well, if you really want to go back to work, we will make that happen. But you need to understand this Christmas might be your last Christmas. So that my wife was sitting right there. It was very painful to hear. And she looked at me and she said, okay, you're quitting. And so I had to quit working, which was one of the most challenging things of my entire life. But it forced me to take an inventory of my life and see what was really important. But they were the first time somebody was willing to treat my air hunger without fear, right? People wanted to help me. They gave me the Hycodan cough suppressant, which worked for a little bit, but I needed something significantly more to treat this. I was so debilitated. I couldn't rehabilitate because I couldn't breathe, right? And so I would become what I used to call a sweaty mess. I would go to the rounds, start at rounds at bed one. By the time I got to the end of the ICU, I was sweating, leaning on everything, and I couldn't hardly breathe, which really wasn't the greatest situation for anybody involved. But now I got to the point I couldn't walk my dog. And so that was my challenge that I posed to them. And so they kind of forced me to see things in a different way. And so I had to take time out and learn to live with this chronic disease. And I had to find my village. I had to accept the help. I did not want to take morphine, right? I'll just be honest with you. I didn't want to take it. I don't have a family history of addiction. I wasn't worried about that for myself. I didn't want to accept that because taking that meant something, right? It meant to me that things were going in a bad way. But I had to accept the help because I needed to be able to breathe. And so you learned how to practice some resilience and pick yourself up, as they say, by your bootstraps, right? And had to learn to give myself grace and patience. I don't know how many times I met with my palliative care. And you're like, you're just going to have to forgive yourself and let yourself rest. We're all type A. None of us rest, right? When we're off, you're writing your papers, you're going through your notes, you're thinking about other things, or you got your kids and your spouse and all the things. We never stop. But I needed to spend some time and rest, recover, right? And that was really what I had to learn to do. And I had to learn to live with my disease. And so for me, that meant turning my dog into my service dog so that I could walk. And he's like just perfect little dog. He's just the best. His name is Disney because I'm a Disney nut. And being comfortable with being uncomfortable. So I had to learn, oh, sorry, that's so blurry, but to use my little best friend. And so this is what I use to get around. I don't work with it, but this is essentially a portable BiPAP machine. I don't know if people can see that at home, whatever. But it's a nasal mask that has a battery and a little side pouch and it's a sort of it's supposed to be used for portable, sleep apnea, right? But I'm not using it in that way. I'm using it for ambulatory CPAP, essentially. And when I have it, I can walk. I can actually do the things that I want to do, such as go to Disney World. I wasn't able to go. And then this is me when I started palliative care. I couldn't walk except with my cane and then I needed my scooter. And I needed my BiPAP to really walk and do something that I wanted to do. If I was in my scooter, I could be okay. I would need oxygen every once in a while. But that was me. And without doing that, I wouldn't have gone anywhere. I would have laid in bed and probably died. And so for me, I think that there's another connection here where palliative care doesn't just stop at palliative care, that leads to enhancing your curative therapy, right? Because this made me having less obesity and more muscle mass and less catechol surges from all of the air hunger led to improvement of response to my immunotherapy, right? It all sort of works together because we all know now that overweight and these sort of catabolic states are inflammatory, right? We know that now. And so it all works together to enhance the outcome. And so getting to the end of this huge big diagram that I thought made sense when I put it together, and I still like it, but it's a lot. When you get to your fear, you get your treatment, and patience will ultimately lead to improvement. And that ultimately improves your quality of life. And so over time, just to give you a sense of my history, and this was in 2022, and then October of 2022, and January of 2023, and then September of 23, and December of 2023. And then finally, on March 1st of 2024, I achieved my goal, was going back to work. Part-time. I do very little clinical work at the moment and mostly doing research. I do about a week, a month of service, with a lot of support and I'm very thankful the university has been very supportive in getting me back to work and appreciating what I've done and what I do. And so I had to reimagine my purpose in life, right? And that ultimately leads to acceptance and gratitude. After all of this sort of recurrent living in the stages of grief, you have to deal with the trauma, by the way. Do not forget the role of psychotherapy in these patients. They need a lot of it. We need a lot of it. And it is traumatic. And somebody who specializes in trauma, it would be my recommendation. And then ultimately, acceptance and gratitude helps you find joy. And you can't do it alone. Encourage people to find their village, right? And then empowerment. So, using this and getting around, I made things work for me. Help your patients. I'm in support groups for patients with this. And I post pictures like this because I try to help them. But they get a lot of, they say, resistance from their physicians to think outside the box. If your patient has a chronic debilitating disease that they're going to die, I would encourage you to think outside the box. You may have never done it before. That's okay. And so I fortunately have a good pulmonologist who is like, look, you do what you got to do, and we make things work. And I'm so passionate about this. In a week and a half, God willing, I'm going to the American College of Rheumatology to talk about this very topic of utilizing palliative care to optimize outcomes for this condition. And then once you achieve joy, you can ultimately find hope. And I think hope is really what the key to getting through any disease like this is. But it's not always easy. But in my opinion, it's always worth it. So this was just a few months ago, and this was a few weeks ago. I needed some more time at work, and I had to take a break. But that's okay. That's where the grace comes in. And the last thing, a couple of things I'll leave you with, just some disjointed things for every patient disease. Their disease is rare. So it's all scary in their own way. So they all deserve our care, empathy, and compassion, which you guys provide every day. And to train, I'm going to take a minute and protect your biggest financial asset, which is your career. If I had not taken the advice of my financial planner when I finished my training, my family we would have lost our home. We would have lost our assets. We would be in a very different spot. We'll just put it that way. So work with somebody and protect it, and do it right when you're done, so that when you get your pay increase, you don't realize the difference and it'll all work. But this is critical because you don't know. I had no thought that this would ever happen to me, and nobody ever does, right? So, but just with a little face trust and pixie dust, you can get better. So thanks. I'm happy to take questions. I really appreciate the invitation, and I hope anybody found some things helpful and interesting. Thank you.
Thank you so much, Dr. Sparks. Are you able to hear me?
I can hear you a little bit.
Okay, cool.
Oh, that's better.
Thanks. Just before taking chair's privilege, sorry I had to get on a plane, but I couldn't miss any of this. It was absolutely an incredible journey. And it calls to mind, as you know, starting in November of 2022, the public essentially had free subscription, if you want it, availability of AI with ChatGPT, and then other services have grown as well. And the question is, if you had the opportunity, and maybe you've done this already, to put all of your symptoms, every single one of them, everything that you'd experienced, into an AI chat box, could it have come up with the diagnosis and helped out a lot sooner?
So the answer is I don't know for sure, but I have done it, and yes, it comes up every time.
Amazing. Amazing.
Every time it comes up, and not even all of my symptoms. It included it with just a few key symptoms. It creates it, and there's some symptoms that are really esoteric. So routinely, I will kind of have a cold, but with no, I hate to say, but no snot. Like, and what that is actually inflammation of the nasal cartilage, and putting no secretions and nasal obstruction or nasal what did I put in? Something similar to that, and it came up as number 1 and 2 as a possibility to consider. And so it came up repeatedly in AI. I have my own sort of questions about AI, but it did come up. But honestly, my search in PubMed, it came up too.
Well, thank you for that. And perhaps that really is the way to go forward.
Hard to know yet, but I think it definitely in these rare diseases, if you have a patient that's stuck in a diagnostic odyssey loop, I think using whatever tools you have at your disposal to try to broaden your differential diagnosis. Nobody's going to think of this. Most people have never heard of this. So you can't diagnose what you don't know. You can't diagnose what you haven't thought of. And so I think using AI, particularly when you feel like you have a patient that's not responding or not following the typical natural or unnatural history of your disease, that's when you got to find some tool set, some toolkit to try to broaden your differential, if that helps.
Absolutely. Thank you.
Any other questions?
We do have a couple in the chat in our chat area. One of them is from Dr. Robert Evans. He's in our bone and marrow transplant group. Wants to know, was there any literature or philosophy that helped you gain perspective and cope?
Well, yes. One book that helped me was The Body Keeps the Score, and I'm blanking on the name of the author. But it was, I think that I didn't appreciate the amount of mental trauma that was being caused by this, and how it compounds your, all of us carry our own baggage, right? And how it sort of compounds that. And so I think that was really helpful. And then there are a few books, wasn't expecting this question. It's a great question. But there are a couple of books. One's called Shock, I believe, was about a physician who had a major complication from her pregnancy, and actually emailed her, and we went back and forth a little bit in a positive way about discussing about our experiences. And actually the movie Doctor, if you've not heard it, I think it's called The Doctor. He has a throat mass, and he's an arrogant surgeon, but then kind of learns about what it's like being a patient. Not that all surgeons are arrogant. Oh my God, no. He was an arrogant surgeon, and learned that. So.
We have one comment from Dr. Levinson. He's one of our retired researchers. He says, very nice and important talk. As a lab director for almost 50 years, I have many times seen testing that made me wonder about the diagnosis in the record. I have found it is always wise to look at the past testing and symptoms in the record and see if I think it agrees with the listed diagnosis. If not, to make a suggestion to the attendings to reassess.
Yeah, I just think it's important reassessment. Like, I don't hold any ill will toward my doctors. I sometimes get frustrated, but I don't, because these are rare. It's sort of like, as a pediatric cardiologist, pediatric heart disease is rare, right? 1 out of 100, so it's not that as rare. But when a child comes to the ER in the middle of cold and flu season with a fluffy chest X-ray and some wheezing, the first thing we think of is not cardiomyopathy. It's not obstructed total veins. It is not that, and it would be foolish to start getting an echo and everything. So I think it's the reassessment part and understanding that your diagnosis, majority of the time, I hate to give 100% on anything because I think that's not correct, but it's always presumptive. Right? You're making a presumptive based on our understanding of what we know about the patient. And the failure to reassess is when I think physicians miss the opportunity to do the right thing for the patient, is making sure what you're doing is helping. And that's the biggest thing that I could leave you with, is reassess and make sure. I was on every asthma therapy known to man, which is what my pulmonologist finally said. He's like, I don't know what's wrong with you. I just know that it's not asthma. And I had a pediatric pulmonologist who did some iOS oscillometry, and I had really no small airway involvement. And he's like, this is not asthma. And honestly, if you know a lot about tracheobronchomalacia, bronchodilators can worsen symptoms. So I was on these long-acting beta agonists that actually probably made my symptoms worse. So, and to answer the question as to why haven't I had this fixed, that was a question that I talked to the leading surgeons in Michigan who do external splints on airways, and they felt I was not a candidate. And I spoke to Dr. Gangadaram at Beth Israel Deaconess, who is the leading guy on tracheobronchoplasty, and he felt due to the diffuseness of my malacia that I would not be a likely responder to the disease. And he was very honest that the outcomes, some patients can have a good outcome, but the complication rate was approximately 50%. And so currently palliative care is the best option we felt for me and my family.
We just have one last question in the chat for one of our folks wants to know, says this is very inspiring. She says, my son has a rare disease which has been debilitating. At 26 years old, he reached out to palliative care for assistance with symptom management. Unfortunately, the provider labeled him as quote unquote drug seeking and rejected him as not appropriate for palliative care. Would you recommend trying again?
Yes. That has not been my experience with palliative care, not knowing her son's condition and the situation, but I have not had that experience in any way with palliative care. So I would do it. I would try again, would be my only recommendation. I mean, I think, this requires a team effort in understanding the role of palliative care. And obviously every system has their maxes and you don't want to overload the system. But I do think there is a limit to where primary care physicians can palliate symptoms. And then that either you could go to a pain doctor, or ultimately, I think palliative care can refer to a pain doctor as part of their palliation, but I think them being part of the care coordination is very helpful. And I'm really sorry that they had that experience, because that's not been my experience with them at all, at least locally here.
I think there's a variety of like private and palliative services, and so finding the right.
Yes, I do. I use Palliatus. I don't mind saying that. And I think they've been wonderful for me.
That's all. So.
Any questions?
I just had a comment, Josh. Thank you so much. This is now the second time I've heard this, and it's at least as fascinating as it was the first time, and I still took things away. I think as a hospitalist, I see people in a variety of spots in their odyssey, and it can be really difficult because the patient has heard and said a lot up to that point, and so for me to chart review everything and also disregard some of the chart that has pre-populated in the days of everything pulls into a note now, and it does give us more bias sometimes. To sit down and actually take that full H&P can be difficult. And so I really try to sit with those patients who've had a very long journey and say, here's our expectation setting of, it probably won't come up with an answer while you're in the hospital, and we'll look through everything again, get a new set of eyes. This may just be the beginning of some weird stuff, and it might resolve, but if it doesn't, like this is chapter 1, so I don't know how this book is going to look for you and how it's going to turn out. I think that's helpful for the patient coming in who thinks that they're coming to UofL for a second opinion and they're going to get an answer right away.
Yeah, I think that's really good insight. I try and, I participate with the Relapsing Polychondritis Association and their support group, and try, because there's a lot of resentment toward physicians in groups like this that I've noticed. And I understand where it comes from, and they don't understand how physicians think. They don't understand the challenges of coming up with these diagnoses. And so I try to navigate that and help them, especially understand that an inpatient setting is really not the place you're going to come up with these types of diagnoses and things. But I think that is hard, and especially in the hospital, when they want answers, and it's really challenging to find an answer. And it took me 10 years, and I was a physician, right? And so I think giving you perspective that even as one of us, it took a decade to get to the diagnosis. But yeah, I think I appreciate that. I think just, recognizing whether your patient's following the pattern or not, it's pattern recognition, and it's hard when you have your beepers.
As the attending, I'm not always taking a full H&P.
Yeah, exactly.
Sitting down when something doesn't make sense and going back in the room and really like getting to the meat of let's go through all the symptoms and
Yeah.
having things started, and it's a lot of time.
Yeah, I think, and unfortunately, I think in some ways medicine is moving to help these patients with more genetic testing and total genome and making that cheaper and things. But I had a total genome and a total chromosome, and it didn't find anything. And so I think the medicine in some ways is also getting harder to recognize patients like this because we have less of us. We have less specialists. We have, less of the expertise and less of the time. And that's really what it took to come up with this was the time and the expertise. Once I got to Marcy at the NIH, she made the diagnosis in 5 minutes. But after, you know what I mean? So that's the problem, is trying to find who to get it to. And one of the things, the last thing I guess I can leave you with is, not being afraid to go to the authors of the papers. So if you find a paper, you always have that corresponding author. That's how I found Marcy. I emailed her and she said, call me. That was her only reply, and gave me her cell. And so I think, us as physicians, remembering that there is a way to reach out to these people on those papers who wrote this up, and they can be extraordinarily helpful at getting you to the right people. Because there's really only 3 centers, Penn, NIH, and then France, as Strasbourg has as a center, and there's one in China. That's it, really. So.
I'm a primary care physician, but have, let's just say, dabbled in palliative medicine over the years. So since I don't see a number of palliative medicine folks in the room, I just wanted to say thank you on their behalf for featuring the importance of palliative medicine in your journey. And to say for the person who made the comment in the chat, or anybody else who's listening, that I think we have good news here at UofL, that our palliative medicine mission is really growing and expanding, although it's been in place for over 20 years. It's just in the last few years that we have a dedicated division of palliative medicine, and that we finally have a system of outpatient clinics.
Oh, that's great.
To which adults can be referred. Versus for years before that, we had a very strong inpatient presence.
Yeah.
But that would not have been as helpful to someone like you who is on a longitudinal
Right.
journey.
Yes.
And I think, as somebody who has been in the position where, I was sometimes a hospitalist and sometimes a palliative medicine consultant. I covered palliative medicine on Wednesdays once upon a time.
Yeah.
And I will tell you, my mindset from Tuesday to Wednesday was totally different.
Yeah.
And it was very eye-opening to see, like, hey, this is a really different perspective. Now, after 20 years of practice, I think I've done a better job of converging those things, but they're still not the same. Yeah. And so even if someone has a primary care physician who is very empathetic and willing to treat symptoms, et cetera, I think there are limits to
absolutely
what we can achieve in primary care. And so in some cases, select cases, but probably far more cases than we actually admit to, having palliative medicine on board is so important.
I totally believe they saved my life. I believe that with every ounce of me, which I think is the irony to what people think of palliative care. Yeah. I think they saved my life. If they had not been willing, or if I hadn't found the person to treat my symptoms, which took opiates, I'm just being honest, right? You have to treat the symptoms. And that's what turned things around for me. And so if I would have continued on you saw me, didn't look like a person who was going to live much longer. Had not got, and it was solely treating my symptoms and some motivation. But when your symptoms are better, you're motivated to move, and it's all a package. It's not just the MS content. It was that and therapy and all the things that palliative care puts together, and their social support and everything. It's a comprehensive palliative process. It's not just one thing, right? These patients require extensive medical village and a social village, and